welcome to Critical Care Northampton with Jonny Wilkinson. Today we're going to be discussing all things inotropes and which one's best for your patient. Enjoy.
It's time to delve through the best of papers. My God, check those infographics. It's the best out there for phone med and all things critical care, You want to talk the best on X? It's just the best POCUS. My God, is there a podcast better than mine? Check out the crazy websites. Critical Care Northampton.
Well, hello, ladies and gentlemen, and welcome to vlog number 2 of criticalcarenorthampton.com, where we bring you all of the best in critical care, phone med, Twitter, papers, videos, etc., etc. The list goes on. So, without further ado, we will crack on through. These are all the things I think you need to know. By the way, I'm Jonny Wilkinson, consultant anaesthetist and intensivist from Northampton. Anything you hear on here is nothing to do with the establishment that I work in. Let's just get that straight. Nothing else to say really on that front. So, what have we been pulling out for you? Well, let's take a good look through the archives and see what we have.
This is the news section.
Indeed, this is the news section. So what have we pulled out for you? Well, let's have a good look. So first of all, I wanted to point out this little catch-up video from RA UK. Here we go. Listen to this.
Am I late?
Did I miss it? Did I miss it?
Well, it's not too late.
So what did I miss?
Once upon a time, in the middle of an Excel lie, faking loves melted oils, throwing dollars and dice.
Do you wanna stand beside a hologram of your life? Love is waiting in the middle of an Excel line.
If you wanna fall in love in a bar tonight, do you wanna fall in love with a broken heart? Do you wanna ride in the rush? Do you wanna be the one that feels that boom boom bang?
There you go. There's some fantastic stuff from RA UK. And it just is a sort of highlight of the meeting itself, which was phenomenal. It was fantastic. We had lots of POCUS in there, loads and loads of stuff. Do you know what? Every time RA UK runs each year, you think to yourself, how can you reinvent the wheel with regional anaesthesia? I mean, meeting after meeting, the crew deliver. So if you've never been to an RA UK meeting, you need to go to one because it's fantastic. But do have a look through. You can actually, if you weren't there and weren't a delegate, you can pay for full access to all the lectures and stuff. So that's quite well worth doing. Anyway, so we'll move on and let's have a look at the next thing I've pulled out for you here. Now, this is a good one. So here we've got PUMCRIT. If anyone's not seen PUMCRIT, it's a fantastic website that goes through loads of critical care stuff. And in this, we can see that they've produced a T-shirt, and it's all a bit of a joke, frankly, but blotted face of sun there. More fluids, really, bro. Very American, but it's just stressing the point that we should be a bit more careful with our IV fluids within critical care environment in particular. And even nicer, if I play through here, you can actually order your own because the template's available. And if you click on here, it takes you to Canva. You can actually get your own T-shirts made. So isn't that great? So that's a good one from PUMCRIT there. Just a bit of light-hearted stuff, to be honest with you. What else have we pulled out now? This is good. This is ORCA. Now, if you don't know what ORCA is, it's online radiology for critical and acute care, and it is run by my very good friend Manoj Wikram Singh, singer. Do you know what? I've known Manoj for ages, and I never get his name right. I'll be seeing him on Monday, tomorrow, in Newcastle for Sono UK, so undoubtedly he'll tell me off for mispronunciation. Anyway, Manoj has set this fabulous website and resource up, which you need to register for. And if you look down here, there is a link, it take you to the registration page. I am telling you now that this is one of the best accreditation, or if you like, education resources for ultrasound, aside from the resources available on Fusic and various other ones. And it has all been done by Max Ridley, Manoj, and a couple of the other crew and leads. It is phenomenal, so please get yourself registered for ORCA. There's some really good stuff on there, from the most simple to the most highly advanced. It's a whole body ultrasound protocol, so well done to Manoj and the crew in Leeds for that absolutely phenomenal work. Now, the next thing I've got here is all about, if anyone knows Paul Wishmeyer, he is a physician from America, and he suffered from bowel obstruction and had a major GI fistula and a long time on intensive care. Now, if you look here, this is his fabulous rehab video, and it's just emphasising the difficulty he had and the importance of rehabilitation post-critical illness. Fair play to him, because it was obviously a heck of a lot for him to go through, and he's put his life and the rest on here for us to see. And again, if your units don't have people in charge of rehab, you must do this, because it's such an important thing, rehabilitation and or follow-up of patients who've been critically ill, so we can avoid PTSD and stuff. And bless him, look, he's got his TPN line dangling down there, not quite getting caught within the weights mechanism or the treadmill, but, you know, it just goes to show what you can do when you put your mind to it with rehabilitation, but support is paramount. So well done, Paul, for that one. Hearts go out to you. Now, this is an interesting one. It would be to do with POCUS, knowing me, but Ross has put something forward here which is very interesting. Now, what it is, you please have a look through the links. And again, the article with the links in is there for you at the bottom of the chat. Take you to Dropbox. You can download it and have a look for yourself, everything I'm talking about here. This really is an article which examines cases within law, litigation, where POCUS could have been used but wasn't used. And it has got to the point now where perhaps if we're not using POCUS and we have the ability to, we are doing a disservice to patients. And certainly in this article, which I'll show you here, there are medical legal implications, put your teeth in, Jonny, involving not using it. And the article is well worth a read, because it goes into the logistics of all of that. So it was mentioned at RE UK by Rosie Hogg that actually people are getting into a bit of trouble for not using POCUS when they should have done. So what else have we pulled out for you? Let's have a look. So we're now going to move on to a different section here. Here we go. Here's another section for you, if I can press the appropriate button on my console.
These are the best websites.
I'm back. There you go. I mean, it's teething issues, isn't it? Pressing lots of buttons, fiddling with a mixer and all those things, because I guess those are the bits you don't see, because after all, I am floating around in space, as you can see, with a massive spaceship of critical care Northampton above my head. But here's the best websites that I've picked out for you. So let's have a little butchers. And obviously, it wouldn't be me if I didn't take to Crit Care Reviews and then take you through the newsletter. So what have I picked out from the Critical Care newsletter? Here we go. Let's have a little look. So the first article here is about blood pressure management in intracerebral hemorrhage. When, how much, and for how long. This is always a bit of a contentious issue, isn't it? How high or low should the blood pressure be, and so forth and so on. I think it's a very important concept to get it right, because the patient needs to have secondary brain injury minimisation, of course. But sometimes you get advice that's different. It depends where you are. Please look at the article, because they are suggesting what the best systolic and perhaps mean arterial pressure targets are. And this is looked through a large database large abstract and evidence trawl into the subject, so it's pretty good, pretty up to date. So please do have a look. Now, I'm not going to wax lyrical about it because you can read for yourself, but I just wanted to point out that article because I think it's a really useful one, particularly for people who might be out in the district general setting, not in a neurointensive care setting. And the next article I wanted to point out is this one. And this is all about recent data about the use of corticosteroids and sepsis, because obviously we think it's our bread and butter, isn't it? You've got sepsis and associated septic shock. It has become mantra to use steroids, but actually this article discusses beautifully the pros and the cons of the use of steroids, because we all know you get swings in blood sugar, you get all kinds of things going wrong. But equally, it examines the evidence to say, yes, there are things that go wrong, but probably the benefits outweigh the risk. But there are things within this that I hadn't actually considered when giving steroids to people. And I think a very important part of it here is, as you can see, is the genomics in sepsis treatment. There is the genomic trial going on, which is looking at the sort of genetic phenotyping of sepsis, because we all know now that sepsis is not a one-size-fits-all thing, and it depends on the patient, and it depends on the circumstances, it depends on what race you are, etc. So this is a really lovely article, not too long, all about steroids, the benefits, and so forth and so on. So that's well worth the read. I thought I'd point that one out to you. The next paper I noticed, and again, critical care reviews meeting is next week, and also I want to again offer up a round of applause to the fantastic Rob McSweeney, because without him, you know, this meeting wouldn't be what it is. So Rob must be bored of my Jonny Wilkinson round of applause, but I'm giving him another one. There you go. So Rob McSweeney, critical care reviews. Anyway, this article here, clinical markers in heart failure and narrative review. Again, I'm not going to talk too much about this, but look at this table here. This talks about all of the biomarkers associated with damage to the heart. Now, obviously, we associate in many places high sensitivity troponins, but this goes into all sorts of research-based markers as well, and some of the newer ones, and indeed some of the older ones, and how relevant they are and what the evidence base is regarding outcome from patients who've got myocardial damage. Good article. Have a butcher's at that one. Gratuitous plug, ladies and gentlemen. We wrote an article some time ago about brain natriuretic peptide, and is it worth paying attention to it? Because this is obviously something which is elevated in mainly an atrial stretch, actually associated with heart failure. It is called brain natriuretic peptide because this substance or compound was discovered in the brains of monkeys originally. Poor monkeys. Anyway, the chimp or whatever it was, or whoever it was, the bonobo, I don't know what it was discovered there. And you can see that it is released in large quantities when there is myocardial damage. There's some beautiful graphics in here, but it's going on about all of that in quite some depth in the article I've just mentioned. And indeed, we wrote this blog, if you like, all about it. And I'm saying beautiful graphics. These are ours. So I'm bigging up my own graphics here, but some of them are ours, some of them are taken from other articles, and the accreditation is given obviously below. So do have a look at this about BNP. Should we look at it? Should we pay more attention to it? Have a check for yourself. What have we got next? Sorry about that gratuitous link to my own website, but there we go. Now, diabetes. Do you remember last vlog we talked all about Wegovy semaglutide and the GLP-1 receptor agonist drugs? Well, Anesthesia have released this fabulous summary article, which I did get a hint about from my good friend Matt Wiles that this was coming. And I'm glad it has, because this talks all about what the implications of general anaesthesia and patients who are on these drugs. And it talks beautifully about the physiology and the pharmacology of how the drugs work and what they do. Now, if you look at this table, this pretty much tells you everything it does. So this stuff has quite a profound effect on lots of organ systems in the body, and in particular gastric emptying, as we've been harping on about for quite some time. But do have a read, because they've got a beautiful summary for you and some suggestions of possibly the fact that patients are not in fact empty from a gastric antrum point of view, certainly until 3 half-lives of the drug have passed. And that can be sometimes 48 hours later. So this is quite scary stuff. And again, please be vigilant with your patients, and if they're on this drug, make the presumption and assumption the stomach is not empty. Next thing is all to do with kind of neuroprognostication, I guess, and this is all about regional brain net water uptake on CT after a cardiac arrest. The paper discusses the fact that the development of edema after a cardiac arrest, and that indeed that loss of grey-white differentiation we see on CT scans, which is usually a bad prognostic marker along with an EEG diagnosis of severe cortical dysfunction. We're looking more and more at other things to back up our opinion on whether patients are going to have a good outcome or a very poor outcome. And indeed, it has implications for organ donation, donor brain death, which is declared by two clinicians, first of which does the first test. And if the first series of tests are positive, then that is a declaration of brain death by diagnostic criteria, neurological criteria. So this goes on about this potential new marker and or CT imaging series that could be added on. Now, the problem with these things is that your radiology department may not offer this, may not know anything about it, and indeed it may just be a research tool. However, I think it's adding a little bit more fuel to our prognostication, particularly when there are contentious cases in court, and there have been situations where there's been quite a nasty run of litigation going on over declaration of brain death and things like that. Now, infective endocarditis, not everyone's bag. However, there are the 10 commandments, and the 2023 European Society of Cardiology pulled these guidelines out from Rob's list from the EHJ. And this gives you sure enough, those 10 commandments: prevention, a team, diagnosis, etc., and it goes on all the way through to do what antibiotics to give, what surgery to offer. Really, really nice paper to have a look through. So please do have a little bit of a dig through that one and see if you fancy changing the way you consider these patients, because I think it's given me some education, certainly, which isn't difficult. Next, it wouldn't be me without going across to the fabulous bottom line. And I've picked out the danger shock trial. And this is all to do with microaxial flow pumps in myocardial infarcts with related cardiogenic shock. Are they of benefit? Now, clearly not every centre does these. It's usually a tertiary centre that offers it with a 24-hour cath lab and or a surgical backup with bypass, etc. However, this paper looks at adults presenting with ST elevation MI and cardiogenic shock as a result of that, whether these impeller microaxial flow pumps were of benefit compared to standard of care, which essentially is without them. And the overall opinion was that these pumps led to a lower risk of death in cardiogenic shock once inserted at 180 days. It was statistically significant, so this is something to bear in mind when referring perhaps to a tertiary centre in someone with cardiogenic shock, because perhaps we don't do that enough. I don't know. I'm sure you guys are really good at these referrals, but I think sometimes we don't refer early enough. So there we are. That's the bottom line's latest one. Certainly this last couple of weeks. Now, Life in the Fast Lane. I should have mentioned this before. I love this website. You just need to check out Life in the Fast Lane. Fabulous. It is loaded full of absolute gems. But I picked out this one about new causes of cardiac arrest you never thought of. Great video here from Cliff Reed, and it's all about the consideration of actually 1, 2, 3, 4, 5 H's, 5 T's, and 5 C's as well. These tend to be the slightly off-the-wall ones. You've got cerebral cause subarachnoid hemorrhage. That does cause cardiac arrest through myocardial dysfunction. The cardiomyopathies, your conduction abnormalities, and this one in particular, the commotio cordis. Do you remember the American football player who unfortunately suffered from a severe blow to the chest? And it happens at just the right point on the after the QRS complex. It happens just at the wrong point, and it actually then sends you into a cardiac arrest. And it's quite rare and quite difficult to do. But if anyone is interested, there is a video of a said American football player going down on the pitch as a result of what happened to him. And it's quite harrowing, if I'm honest, but you can check that out at your leisure if you want to have a look. So that's commotio cordis. So anyway, it's now the 6 H's, 6 T's, and 6 C's of cardiac arrest. So that was a very interesting one from Life in the Fast Lane. I love their laid-back style. So what do we have next for you? Well, obviously the next section goes without saying is all to do with papers. So we're going to move on to that. And what I've done here is I've tried to keep it as brief as possible because, you know, you could go on forever about all the papers that are released. So let's have a look and see what we've got.
Here are the best papers.
Indeed, here are the best papers. Well, I thought the best papers anyway, so should we have a delve through? I keep going very wide-eyed here, but it may be to do with the light above my face and the beautiful stripy shirt I'm wearing, which should have some treble clefs on it. It looks like some musical score should be written over here. And I'm also using this wireless mic, which I think is a bit better, actually, because I'm less tempted to try and chew into the muffled cover of the existent mic and or punch it, which kept happening in the last vlog, but I'm sure that gave you plenty of amusement. Anyway, shut up, Jonny, let's move on. Papers, right. Here's one from the BJA, and this is all about metabolic acidosis. Now, you can have a look. The link is down there in the sheet, in the chat, but it's talking about persistent acidemia and actually what happens. And let's remember that acidemia is a state where pH is down. Acidosis is where you've got a cause to that pH being down, similarly alkalemia and alkalosis. And it goes on in quite some depth about things you may not have known about to do with metabolic acidosis and critical care in particular. And you can see here that it's a free open access one, so thanks to the BJA education for this. I love the way more and more things are becoming free and open access. The FOAMed movement is becoming, it's going from strength to strength, so please have a look at this. And if you really want to get down with the equations, as some of my good friends and colleagues get very excited about these, got to be honest, it doesn't float my boat too much. However, the prose does, because it's a beautiful article all about metabolic acidosis and critical care, so please have a read of that. Vexus in heart failure, and this is the Journal of the American Society of Echocardiography, and they're now looking and paying some interest in venous excess ultrasound scores in acute heart failure and seeing what benefit Vexus may offer in the morbidity profiling and survival of patients with cardiac failure. Performing Vexus in cardiac failure clinic patients is very beneficial, as my good friend Felipe Rolla has clearly demonstrated, because he runs, I frankly think if there was an MBE, OBE deserved out in, certainly in Canada, it would be Felipe who should have that, because he's doing wondrous work for patients with heart failure using Vexus, venous excess ultrasound. Please have a look at this paper. And hats off to Felipe and Andre Denault et al. For the original work. Now, we all know that patients who come for surgery, pre-op assessment will see them and they will stop the angiotensin converting enzyme inhibitors or ACE2 receptor blockers, because there is a theory that acute kidney injury can be propagated by continuation of these drugs. Stopping them obviously may have implications on hypertension, certainly afterwards when things normalise. However, I think the benefit of stopping them outweighs the risk, and this is also discussing that in conjunction with acute kidney injury post-operatively. So another good article there to get your teeth into. Now, this one here, I've called this drowning out. Now, this is all about resuscitation fluids. This is the European Society of Intensive Care guideline on fluid therapy, plus part 1, choice of fluids. This is really good because this has got your sort of Delphi classifications, your evidence behind, you know, crystalloids. We don't really use colloids anymore. The only one we would use potentially would be albumin. Blood's obviously a natural colloid in bleeding. But it goes on about the evidence behind these. Now, you know, I see a lot of albumin being splashed around, and I think sometimes without thought. There are a limited spectra of treatment opportunities where albumin works in critically ill population. Obviously, there are implications for giving this stuff to patients with chronic liver failure and things like that, perhaps in a large volume paracentesis. But this gives us their opinion on fluid therapy and what choice of fluids we should be giving. So I think it's a really nice one. So do have a little look into that one. Another one we love to hate Here's the European Heart Journal ERS guidelines on the diagnosis and reclassification of pulmonary hypertension. As you can see, there is a large amount of information here, but moving into the diagnostic criteria and so forth, we can click through, and they have categorized it here, and you can see there's some good graphics to take away and look at. And because I think traditionally right heart catheterization really were the only way you could diagnose it definitively. There are obviously other pointers, severe TR and TR Vmax, but this article really brings it all together to try and clarify this morbidity and mortality generating condition, because it can be pretty horrendous, and also it's got anaesthesia implications too. Now, MRI scanning, I think we all learned about it, certainly during the FRCA exam, the FRCR, obviously they know it intricately, the radiologists. Here's a really brief article about what T1, T2 weighting is, what MRI is, how it works, and so forth and so on. Really nice. There's a lot coming out on PhoneMed from the radiology contingent. I really like it, so well done to all of you. Look at Radiopedia, that's a fab site. I'll probably feature it next vlog, but this is a great one to have a look through if you want to brush up on your MRI and your general radiology.
You've got to see the best POCUS.
Indeed, you've got to see the best POCUS, and I'll try and show you the best POCUS, but I'm not going to go on and on because the list, in fact, I've kept it to a minimum this time. The reason I've kept it to a minimum is because I'm going to take it to ZU again. Why wouldn't I take it to ZU? And you know what? Got a mention here for the vlog as well, which is fabulous. We got a mention for last week's, 2 weeks ago's vlog, because with ZU, I don't even need to summarise all the best POCUS stuff. I've obviously picked some out because it's an addiction. I'm just trying to rehab myself out of it. But yeah, ZU have picked up all the classics. They've got some fabulous stuff to do with whole body POCUS, protocols, etc. And they've picked out lots of people's tweets on things, and there's some really good stuff on lung ultrasound, which I think we're going to mention shortly. Oh no, look, there's that article we mentioned about the kidneys. Do you remember this from last time? So they're picking up stuff that we picked up in the last vlog as well, which is nice. ZU, well done. Oh, look, there we are. There's the vlog we mentioned. What an accolade. So thanks to those guys for all their work. And here we are. There's the vlog on there, which is fantastic. And you've probably all tuned into that already, so I'm not going to go on about it anymore because you've seen it. Now, what have we got here? So the next thing I pulled out is lung ultrasound. It's talking about lots of different things that you may not have considered before. And within the article, it's talking about not only B lines going all the way down, but it's talking about X lines. I didn't know X lines existed, although Justin Kirk-Bailey and I were chatting about this. It's where an A line, horizontal cross, is crossed over completely by a B line, forming an X shape. Now, there's all this nomenclature that's been mentioned and things, but it goes on about lung elastography and all sorts of things. You can see that there. I think you can see the website now. Lung elastography's got a good bit of evidence behind it for particularly things like weaning from artificial ventilation stuff. They go on about diaphragm as well. Lots of different things that I was unaware of to do with the different cohorts of pathologies in lung ultrasound as well. It goes on about lung elastography, spectroscopy and all sorts. Look at the list down here. It even talks about lung ultrasound in asthma. And I think in particular, the fact that severe asthma may actually have B lines starting to appear. Now, we all make the assumption that in an asthma attack, where maybe an acute one, there's not really much to see on lung ultrasound. But in fact, we could be wrong. We're not looking hard enough because we make the assumption that that's actually one thing that a stethoscope is good for. Controversial statement. So please have a look at that lovely article from the radiologist all about lung ultrasound. Now, obviously, I'm going to show you some lovely images. Here's a tasty one, and this comes from Dr. Rajesh again. From Gopalan. He's a great guy and produces some fab images for us here. Now, if you have a look here, there's the right ventricle, there's the RVOT, there's the aortic valve there with its 3 leaflets banging away. it looks like this is the right atrium and the tricuspid valve's flapping away here. But it all together doesn't look quite normal because you've got these interruptions here and down here. So the question, and I love these tweets that come out where they're asking, what is it? Well, actually, you've got left mainstem coronary artery and the circumflex coronary arteries, which are all dilated here, and you can see them all the way around. So I think that's a fantastic image to see, because if I put my probe on and saw this, I would be questioning what the hell was going on here, to be honest with you. Be looking at and thinking, you know, what is happening, essentially. Probably call a friend, etc., which we all should be doing. But thank you to him for that fantastic one. I don't think we mention bowels very often when we talk about ultrasound, but here's some images of GI ultrasound. And what they're trying to demonstrate here is severe edema and swelling of the colon. They're measuring the circumference of the wall and things. So there's something going on in this patient. There's also lots of fluid sitting above the spleen here, which has got a jagged edge to it, and there's got a slightly bizarre echogenicity to it. And on here, you can see air under the diaphragm, dilated stomach. And I mean, look at the state of the air under here and under here. I mean, there's barely any chest visible. So I love these because the discussions that come thereon are fantastic. And if you look at this, this is a hugely dilated stomach showing under the left side when we're trying to get lung ultrasound here through the ribs. This is a stomach that is not empty. In fact, it could actually be a loop of large bowel that's dilated. Oh, well, apparently, Vogelustra produces a safe and non-toxic sealant gel. How is that linked to bowel? The other fact you can't use it when someone's perforated, I don't know. But there you go. I've just advertised their sealant. So do get some Vogelustra sealant. I tell you what, I hope they can give me some money for that one. Right, moving on, stop prattling on, Jonny. Now, the IVC, this is my favourite, this. I love to hate the IVC, and I've got a talk on it which I assassinate the thing, because what I want to get across is that looking at the IVC and making a decision on volume tolerance and or your volemic status of the patient is a mistake. The reason being, it should never be considered in isolation. And Ben Millett does a fabulous tutorial here. Let's click it, and you can see down the side, hopefully. Here we go. He's giving some images. Got to be honest, I might nick some of these because they're fantastic. Here is one that's got some collapsibility. Here is one that's mistaken for being an IVC when in fact this is a hepatic vein. So you've got to be quite careful what you're looking at. There's your IVC in the RA junction. But if you look here, the RA junction might be down there actually, and this is just a reflection of the heart above, probably the right ventricle. I don't know what's sitting in there, but this is not an IVC. And equally, the discussion goes about the short axis view of the IVC, which I think is the most validated view we should be looking at when we're looking at the IVC these days. So there's the IVC. Gotta love to hate that one. And finally, and this is me saying finally for POCUS, unbelievable. Where's the pneumothorax? So this is a good one. This is a sort of perioperative POCUS chat, I suppose. And this is from Salman Neem, and he's talking about, you do an RSI, you intubate the patient, there's no breath sounds when you listen with a stethoscope. I mean, all very sketchy. And then you put the probe onto the left side of the chest, and there's no sliding, and no sliding of the pleura technically means pneumothorax. The next thing you do is put an M mode through to confirm it, not always, but sometimes. And you see here what we call a stratosphere sign. You should see the sand, the sea, and the horizon, but this is very stratospheric, barcodey looking, and you should not see that. And here is pleura that's not sliding at all. You can see there, it's just sitting, but it's bobbing up and down with the cardiac oscillations. And if you put the M mode through that, again, see these interruptions here? These are lung pulse. You can only get cardiac oscillation transmission through the M mode signal interruption like this if the parietal and visceral pleura are opposed and together, which means there's no pneumothorax. And of course what's happened here is a simple case of an overzealous and overexcited intubation. It's gone down the right main bronchus, but pull the tube back and it will come back to normal and slide. And of course that lung pulse was there. So that's the bit that tells you there isn't a pneumothorax, and not to get overexcited by lobbing a needle in and decompressing. We don't need another hero, ladies and gentlemen. Thank you. I just thought I'd put that gratuitous link into Tina Turner for you there. So what have we got next? Let's have a little butchers. Let's see what we've picked out for you for regional anaesthesia.
Stop before you block regional anesthesia.
Thank you, Emily. Yeah, stop before you block regional anaesthesia. She was giggling away there again, but you know, these terms are quite funny to a 13-year-old daughter. Clearly, there we are. She didn't know what stop before you block meant either. I don't really blame her because, frankly, the concept is gets a bit annoying, doesn't it, when you've got to do a stop before you block every time, as if to say you're going to put it in the wrong side. But it's been done, so it's a very important thing, ladies and gentlemen. Stop before you block. There we go. Right. So this is all about analgesia for hips, and then in particular the suprainguinal fascioiliaca block, or SIFI block. This is looking at whether SIFI block was superior to not putting one in, if you like, in total hip arthroplasty. Now, the conclusions are interesting. Because they were saying that it didn't confer any significant opioid-sparing effect compared with a sham block. So that's kind of the implication that they're not very good. But I certainly know that lots of my colleagues within the RA UK world and things do use these. I've got to be honest, for total hip arthroplasty, I tend now to use a PENG block, and that obviously comes from the fantastic Philip Peng, and it stands for Pericapsular Nerve Group. Isn't that amazing that your surname is in fact an acronym for the block you've come up with as well? Well, you know, amazing. But Philip Peng's a lovely guy. But I do a Peng block because I find these much more useful than a SIFI and certainly a fascioiliaca block itself. So there you go. Have a read of that. Look at the appendices and just see if you agree with what they're saying on this, because some bright spark will probably pick something out that I've not noticed to say, well, actually, yeah, but in this cohort of patients, perhaps it wasn't done the way we do it or something. The technique and so forth can be very different. Now then, the next thing I've picked out here is all about local anaesthetic systemic toxicity, or LAST. Personally, I've never had a local anaesthetic toxicity in my career, but I do know a colleague who has, and it was doing an axillary block. It was perforation of a vessel, and the use of intralipid actually saved the patient's life. So, you know, it does happen, and it's happened in our area, should I say. So I know it's very important, and yes, we should be calculating toxic doses of drugs and working out appropriate volumes to give within safety remits. But I think the advent of NAP7 and things like that, and other studies looking into the outcomes and things of patients who may have suffered this is a really important thing, because it's something we're all petrified of. But I know certainly my good old grandfather, who's a consultant anaesthetist back in the day, said to me he'll never forget the day a patient said after he'd put a block in, I just feel a bit weird, and that was that cardiac arrest. I think that patient also survived, even back in the day then. So, you know, if patients say they don't feel right after you've injected local, worry. There we go. That's Jonny's tip of the day. So my point is really that local anaesthetic systemic toxicity is a thing, and we should all be being careful in our practice. Okay, there you go. Because I remember Amit frowning profusely when I said local anaesthetic systemic toxicity. Pat, when does that happen? Well, it clearly does. So there we go. Okay, what have I got next? That's regional anaesthesia. Oh, we've got all sorts of, graphics and things like that I want to show you. Now, I tend to go a bit overboard with the graphics thing because it's so my bag. I love it. I love a good bit of graphics and all the tutorials people do. So let's have a good delve into this.
Graphics and tutorials.
So what I've pulled out here, have a guess. I mean, you know, it wouldn't be anything if it wasn't filled with layers stuff, but I'll show you that in a second. So the next thing I'd want to point out here, this is Ihab Suleiman. Now, what I love, and I said this last time, is all of these pathologies. Just have a think. I don't want to ruin it, but if anyone knows what this is, good on you, and you've done your MRCP perhaps. But there you go, there's the diagnosis. I won't ruin it, but the link is in the document at the bottom of the chat. And here's another one. What have we got here? What gory stuff we got here? Oh, yes. So this is a 76-year-old man presenting with difficulty swallowing, and these are his hands. Now, if you have a look, you can see his fingers are white and the skin looks very tight around them. There's little white nodules present as well on the fingers. Why would he have difficulty swallowing? Well, if you're not sure, read on, because it's an interesting one, and I don't want to ruin it for you again, so I'll give you a few surprises in these things. So have a look at this. It's not very nice to see, but if you've not seen asterixis before, here it is, look at this. So this is a patient with true liver flap asterixis. We used to always get taught to look for this. When you go and inspect, you always look at the hands first, and the previous thing I've just shown you goes to a testament to that. But look at this asterixis. This really is very distinctive and obvious. And look, this is the fabulous osmosis. I love osmosis and everything they do. The most fabulous, beautiful graphics, the colours, the font, everything. They're describing the tremor that comes from metabolic encephalopathies and things. So that's a kind of plug for osmosis as well, and all of the fantastic work that they seem to be doing. You must see some of their YouTube videos, they're fantastic. Because of the way I am, I always love to show these images. This is an endoscopy on a patient who's got abdominal pain and bloating. I mean, this is, if there aren't extraterrestrials out there, there clearly are. And this extraterrestrial life form sitting in someone's stomach is in fact a worm. So that's always beautiful to see, particularly when you're eating your dinner, but this ascariasis. And here's the life cycle of ascariasis, you know, how it goes into the food, the embryonic eggs, and go into your mouth, and then they hatch out. What's awful about these things is that, you know, many of these parasites, they find their way into the blood through the liver and through our vital organs, have a bit of a party, do some damage, and then come out the back end again. So if anyone's had a parasite, I feel for you, to be honest with you, because it must be absolutely awful. Although some parasite infections may be beneficial to chronic disease states, some say that it can get rid of asthma, and some say that it can get rid of things like celiac disease and stuff like that. But personally, would I want a 4-metre long tapeworm in my gut just to get rid of my wheezing? Not sure. Anyway, so more stuff from the fantastic Leah Al-Hilali, and she's talking all about neurological stuff. Here is that grey-white differentiation loss in cerebral edema. She's talking about lots of different presentations of the pathophysiologies of brain conditions, cortical restricted diffusion states, deep grey matter, diffuse cortical damage, focal cortical damage, etc., in her typically addictive graphical way. So really, really good. And what I love about Twitter is people start interacting and shoving in some of their images as well. And you tend to learn loads. So I've got links to loads of Leia's stuff, as you can see in the article here. Here's some more stuff to do. Have a look at her stuff, because I mentioned her last time. What about this one? So this is a really nice graphic for you to keep, all about the absorption of various nutrients, electrolytes, anions, cations, vitamins and minerals and things, and what happens. And the interesting thing about this is obviously when you have small bowel, large bowel surgery and they're taking out sections of this, it's pretty obvious why lots of patients run into problems relating to malabsorption, poor absorption, etc., etc. So nice graphic there. Thank you for that. I don't think you ever want to see this one on a CT scan. It's definitely a CT scan because this patient wouldn't do very well on an MRI scanner, I don't think. But anyway, this is a rare complication of spinal surgery. Ooh, you fighter. That screw is either sitting aside the aortic arch and descending aorta, or it's in there. If it is in there, then the patient probably was about to suffer in the middle of that CT scan. But that's pretty harrowing, isn't it? All this metalwork in there. And one of the screws is saying hi to the aorta. Fabulous. God, I'm such a sadist putting things like that in there. What else have we got here? So Jack Fong, what did he put on here? Oh yes, he's just put something quite nice all about rapid sequence intubation, what to do, and a nice algorithm here, and particularly involving paediatrics because it's all peds cases notes. So well done to him. And we've also got something here from nutrition science. Now, this is something I used to teach a lot about, and I think a lot of this is very theoretical, very theoretical. Let's just get this out there now. They're trying to explain which compartment in the body each of these intravenous fluids goes to, how it distributes itself, and how, in fact, when we're trying to replace a litre of intravascular volume loss, some of these may be very ineffective because they're spreading out amongst every compartment in the body. So that's a really nice one. And we've got some graphics on Crit Care Northampton all about that. So do have a little look in and see what we've got on our site too, all of the Turning the Tide section about IV fluids. Everyone remembers Vaughan Williams. There's a nice little one on that one, just to remind you of the antiarrhythmics and the fact that amiodarone crosses all four. And this one I liked because this is an MRCP reminder. I used to have all sorts of silly mnemonics for what puts your INR up and down, essentially liver enzyme induction or inhibition. These are the drugs associated, so have a look at that. I think we've got stuff like that in the mnemonics section on the website. More mustn't miss ECGs. You've got some ALS in the OR. Now, what was this one about? I'm just trying to remember now. Oh yeah, this is from Anesthesia Journal. And it's interesting, this, and it's well worth looking at the paper associated because it's some harrowing stuff actually. 80% use a threshold BP to determine when to start CPR. So I'm sure there have been times during general anaesthetics where the patient's blood pressure drops and you go wading in with your metaraminol, occasionally with something to speed the rate up and a vasopressor as well. But many of us are starting CPR when a systolic BP is below 50, probably rightly so. 50% will start CPR at systolic blood pressure below 40, so that's pretty low, I have to say, even though there may be tangible evidence of a CO2 trace and so forth and so on. I think one backs the other up, but certainly absence and decreasing CO2 with that, absolutely go for it. But very interesting to see that and see what everyone's opinion was on when to and what to, etc. Here is a lovely YouTube video.
Dual antiplatelet therapy, aka DAPT, and you think, why is this patient on these two meds? Should I keep both the aspirin and the P2Y12
Anyway,
inhibitor?
so this is a lovely video. Please
Let's get into this
watch it.
whiteboard animation to shed some
beautiful
light.
whiteboard animation.
First, when you ask yourself,
all about dual
why is the
antiplatelet
patient on
therapy
DAPT
drugs,
and
so
there isn't
well
a
done to the
clear,
guys for
obvious
that
reason?
one. Really like
Remember?
that. I love these bite-sized education pieces. They're absolutely fantastic. Now, moving on swiftly, we're now going to talk about courses because they're important, and I'm going to try and pick out one or two in particular each time we do the vlog, because I don't want you to miss certain courses and so forth and so on.
Which courses should I go on?
Well, which courses should I go on? I don't know. Depends how much study leave you have. It depends if you're a multimillionaire, and it depends how bored you want to be sitting in a crowd after you've stuffed yourself full of buffet food, too much coffee, and you were out the night before. I'm just joking. Obviously, courses are highly important for our CPD. So what have I pulled out this week? Well, slightly biased because I do sit on the ICS Council, but I do want to point out the fact that the state-of-the-art meeting rapidly approaches. It is in Liverpool. It is on the 17th to 20th of June, 2024. 17th of June is actually the pre-Congress workshops. We're doing lots of POCUS stuff. There are bunches of fabulous speakers. There's a great programme, which is pretty extensive, going in multi-tiers. And of course, gratuitous plug again, here's our workshops that we'll be taking part in on Monday. I think on the Wednesday, we've got a really nice session on all of the stuff that I've been harping on about to do with regional anaesthesia. And I'm just trying to find that. It's definitely in here somewhere or other. Where is it? Well, I can't see it there. Is it the Tuesday? Is it the Wednesday? We just don't know, but there's a big session on regional anaesthesia, which I'm chairing, all about fusic blocks. So that's the Intensive Care Society state-of-the-art meeting. It is one of the best intensive care meetings in the UK, so please, if you haven't already, get your tickets booked for that. It may be quite late. If you haven't got the study leave now, you may never get the study leave for that meeting. So it's a bit like rubbing salt in the wound, me telling you that now, but there you go. Now, the coming towards the end now, you'll be, well, hopefully not pleased to know. I'm sure you're all, there are tears forming now because it's coming towards the end, and you're not going to be listening to my wittering for much longer. But I want to mention some of the fantastic podcasts that we would like you to listen to.
Care Northampton, best critical care website out there?
Well, it might be.
I think so.
Or it could just be...
Podcasts.
Let's do that again, because Amelie thinks it's really funny.
Podcasts.
Podcasts, indeed. So, podcasts. Now, I love this one. I'm biased because on Monday last week, or maybe it was the week before, Amit, Jeff and I met, and I've got to be honest, we had the best laugh ever. It was absolutely hilarious. And I got involved pressing various silly buttons on the mixer here and things, but we talked all about fusic blocks, and we talked about blocks and intensive care. We talked about life. We talked about the worst dad jokes you've ever heard. I mean, they were really awful, to be honest with you. There was lots of F's and during it, but we managed to beat them all out. However, it is one of the greatest podcasts to listen to because Jeff Gadsden and Amit Power, their interaction together is really amusing. And obviously me being stuck in the middle of that, it was a joke. And I'm really looking forward to Amit and Jeff's edit, whatever they've done to it, but it comes out the 11th of June. But you must tune in, please subscribe to them and follow their podcast because it is the greatest fun and a very educational podcast to boot. Otherwise they wouldn't do it, would they? I suppose, it goes without saying, really. Again, slightly biased here, but I've got to mention the Critical Care Commute podcast, one of the best intensive care critical care podcasts in the world, founded by Pete Brindley and Leon Biker. They are two of the greatest guys, and they've got all sorts. You can look at all the top episodes. There is a heck of a list of episodes there. If you click the About section, look, Marcus Peck and I are the UK critical care commute podcasters. So I did quite a few fairly recently, but Leon needs to do his funky edits and stuff like that. So hopefully some of those will be coming out. We may be bringing some from the Sono UK conference happening in Newcastle upon Tyne. Pet. That's Geordie, by the way. I'm from Newcastle originally, but you wouldn't know that because I sort of talk all posh now and that. But we're bringing some interviews from there hopefully next week too. So please tune in and subscribe to the Critical Care Commute podcast. Thank you very much, boys. There's the plug. And you must listen to the Anesthesia podcast. This one has got my good friend Kareem on, and they're running through some really nice papers. Now, obviously, Kareem and Marianne running through papers is far superior to me running through papers because I like a bit of a giggle. I like to communicate as best I can in as rapid a fashion as possible, whereas they will break everything down in an extremely intellectual manner, which, depends what you want out of a podcast or a vlog, but you may not get the most high of intellectual breakdowns on papers, the Rob McSweeney, Professor Kareem El-Bogdagli style, but there we are. It's all a good giggle, isn't it, at the end of the day? Please tune in to Anesthesia's podcast and subscribe to that as well. I am trying to speak a little slower this time because when my good lady wife watched the vlog back, she said, "Crikey, you're talking very rapidly there. It's as if you had to be somewhere." Well, I did actually have to be somewhere, but I've tried to slow it down this time. So there we go. Put some comments in the link if you think that I've slowed it down enough to understand this time. There we are. Okay, so those were the podcasts I wanted to talk about. And I think finally, is it to do with meetings? It isn't really. Well, it sort of is. Come on, Jonny, crack on with it.
Which meeting should I spend my money on?
Well, which meeting should I spend my money on? Well, what I've picked out here is it's not a meeting. It's RA UK, but I want to highlight this. The BJA have got an absolutely brilliant flick book edition, a book you flick through, and you can see all of the abstracts and publications that came from RA UK. I love this. Look at this, it's fantastic. And you listen, you even get the page turning sounds. I could sit here all day just doing that. Anyway, more to the point, really good stuff. Some fabulous abstracts there. I went around and had a look at a load of the posters when I was there. So please do have a look. There's lots to learn and lots of really good things you can get your teeth into, particularly in your departments. Right, that, ladies and gentlemen, is vlog number 2. I hope you enjoyed it. I'm looking forward to bringing you vlog number 3. And please continue to follow Quick Care Northampton, the website. Please continue to follow and subscribe to the vlog and the YouTube channel. And I'm Jonny Wilkinson. This is Drum and Bass, and I am going to leave you until next time. Really good to see you all. Good night. See you later.